webinar on behalf of Vijaya Diagnostic Center Private Limited. I'd like to invite you all for today's webinar, the topic being From Ground Glass to Honeycombing, HRCT in Interstitial Lung Diseases. The idea behind these webinars is to discuss practically relevant topics, and this is the recorded versions of this webinars are also available on various platforms of Vijaya Diagnostic Center, and it's for public viewing, and it's generally for the benefit of physicians and general public as such. So today's webinar is focused on HRCT in interstitial lung diseases. And for today's topic, we have two eminent speakers. First, I'd like to invite and introduce today's chief guest, Dr. R. Vijay Kumar sir. He is a senior consultant pulmonologist and critical care specialist, currently working as a director of Hyderabad Chest Center. A very warm welcome to you, sir.
Thank you.
And it is also my pleasure and honor to list out few of his contributions to the field of pulmonology. He was the first to qualify as a pulmonologist from Osmani University in the year 1980, and he was also the university topper. And he has a rich academic experience and work experience of more than 4 decades as a specialist pulmonologist in lung diseases and critical care. He has worked as faculty in Government Chest Hospital. He has also worked as a professor and examiner, and currently working as a professor and examiner for pulmonary and critical care postgraduates. He's worked in all the several prominent corporate hospitals across the city, including Medicity, Yashoda, and Apollo hospitals. He's been the governor of American College of Chest Physicians, USA, for 7 years. He is also the founder president of Indian Association of Respiratory Care, IARC. He is an international fellow of American Society of Respiratory Care, USA. He is also part of the editorial board of several medical journals, including Lung India, IJSD, and IJRC. He's also the vice chairman of TB Alert, and he's authored several books, test books, chapters in books, and has released his latest international textbook on mechanical ventilation for ICU doctors. It's indeed a pleasure to have you with us, sir, and thank you for consenting to be with us and helping us share by sharing your valuable experience.
Thank you.
Our next speaker, I'd like to introduce Dr. Vijayanand, sir. He is a senior consultant radiologist and an administrator. So he's got more than close to 20 years of experience in radiology. He's worked in several corporate hospitals and cancer institutes. He's also finished advanced management program for healthcare from the prestigious Indian School of Business, Hyderabad and Mohali, and he served as the business head of radiology services pan-India of Vijaya Diagnostic Center for almost a year. And following that, he's been working as Director of Radiology for Vijaya Diagnostic Center Private Limited. He's also expert in non-vascular radiological interventions, including lung and other musculoskeletal interventions. He's also an expert in radio frequency ablations. He's presented several papers in Korean Congress of Radiology, European Congress of Radiology, and RSNA Chicago, USA. He's also authored a chapter on MR arthroscopy and interventions. I welcome you, sir, for today's webinar. And so firstly, I would like to invite Dr. Vijay Kumar, sir, to give his valuable clinical perspective in this particular topic of HRCT and interstitial lung diseases. I'm sure we're all going to be very interested and looking forward to sir's input from now on. Over to you, sir. Kindly take over.
Thank you very much, Dr. Deepak. At the outset, I would like to compliment Vijaya Diagnostic Center for arranging this kind of a academic webinars, which will help a large number of practicing physicians of all specialties, because we cannot practice without radiology in our day-to-day work, in our workup for our day-to-day patients. And radiology is the backbone for all investigations. Blood investigations, urine, serology, whatever it is, radiology comes first, and it is the backbone. And there was a time, long time back, before 1970s, when the entire focus was on tuberculosis. Then the focus shifted to asthma, then COPD, and of course, community-acquired pneumonias are there all the times. But in the last 20 years or 25 years, there is a new entity, that is interstitial lung diseases, which has becoming more and more common. And this has been posing a lot of challenge to the practicing physicians in general, and also practicing pulmonologists, clinical pulmonologists like me in particular. And again, for suspecting interstitial lung disease, to classify interstitial lung disease, we have to fall back on radiology. And when I say radiology, I'm talking about high resolution CT scan of the lungs. And when do we start suspecting interstitial lung disease? It is actually when we start listening to the patient who comes and says he has got a cough. Of course, cough less than 2 weeks, we have a different algorithm. Cough more than 4 weeks, we have a different algorithm. For patients who have a suspicious interstitial lung disease, we uh, investigating if the cough is for more than 4 weeks. So, but before that, we need to have a good chest X-ray, because many times it is the chest X-ray which can give us some lead. But then to have a good chest X-ray is a big luxury these days, because we have so many diagnostic centers, and we don't get very high quality chest X-rays from many of the diagnostic centers, especially in the peripheries, in the suburban areas. So I always insist that the source to image distance should be at least 70 inches, and the kV should be 100 to 110 kV. And patients should be asked to remove all the jewelry, all the metallic things, and stand in front of the image plate. And in deep inspiration, when I say deep inspiration, it means where the 9th, 10th, 11th ribs are above the diaphragm. So these days, almost all X-rays are digital X-rays. So if the radiographer can spend a little bit of time, he can create a beautiful image digitally, adjusting the brightness, the contrast, etc. And from there, once we have a suspicion that there is some haziness in the lungs, then that is when we start asking for a high resolution CT scan. So high resolution CT scan is where the radiologist will get CT cuts of 1 to 3 millimeters slices. And many times pulmonary edema can also look like interstitial lung disease. So that is when I would like to ask for a prone image. When we ask for a prone image, if it is pulmonary edema, it will slowly gravitate down towards the other side. And then wherever you saw in the posterior aspect, all those ground glass opacities, everything will disappear if it is pulmonary edema. The same thing happens when the cuts have been taken, when the patient has not taken a deep inspiration. So in the semi-inspiration or in the expiration, sometimes the lung parenchyma doesn't expand well, doesn't aerate well. So you may see some shadows subpleurally. That is when we ask for a prone image. There again, it will disappear. There are some diseases such as acute hypersensitivity pneumonitis, where there is air trapping. because of the non-uniform, non-homogeneous distribution of the air. Air trapping can be seen, and this is seen very well when we take an expiratory film. When the patient breathes out completely and then a CT cut is taken, then we can see the air trapping very clearly. So sometimes, although very nice reports are being provided by experts like Dr. Vijayanand Reddy from Vijaya Diagnostic Center, sometimes uh, we ask for a film to be loaded onto the CD so that I can put the CD in my own computer and then we can scroll slice by slice to especially to look at minute changes, especially the bronchioles and the bronchi, where there can be fibrosis surrounding, which can pull the bronchus from all sides. So there is when we say there is a traction bronchiectasis. So this traction bronchiectasis is very pathognomonic of fibrosis, which is resulting from many interstitial lung diseases like idiopathic pulmonary fibrosis, non-specific interstitial fibrosis, and sometimes even sarcoidosis, etc. So as we go forward, I'm sure we will learn more things during the talk by Dr. Vijayanand Reddy. And I'm sure a lot of questions will be asked. And then during the questions and answer session, we can even discuss more things. Personally, I found high resolution CT scan a big boon for me in my clinical practice because now we have a plethora of interstitial lung disease which can be diagnosed only by the high resolution CT scan, that is HRCT in short. So one of the very, very nasty diseases, nasty interstitial lung diseases is idiopathic pulmonary fibrosis, that is IPF, where the 3-year survival and the 5-year survival is very poor. But then at the same time, there are certain ILDs, such as acute hypersensitivity pneumonitis, which, if diagnosed at the right time, they respond beautifully to the treatment. And there are also other diseases like cryptogenic organizing pneumonia, which is another form of ILD, where the CT scans are very, very pathognomonic. They give a lot of information, and after the treatment, there is very gratifying results to see. So we can repeat the CT scan again after a period of 4 weeks, 6 weeks, or maybe 2 to 3 months, etc., to see how much of improvement has taken place. So in addition to this, of course, there are some man-made issues like drug-induced lung diseases or radiation-induced lung diseases, which can be captured by the high-resolution CT scan, and we can prevent it, or we can start a treatment so that those patients get better faster. So with this brief introduction, I hand over the platform to Dr. Vijayanand Reddy.
Thank you, sir. Yes, sir. Thank you, sir, for that wonderful insights and clinical perspective. Sir has spoken about how the technique of chest X-ray and HRCT is so important to deliver good quality images so that we make an accurate diagnosis, and how also it is important to see the entire data set of the images rather than just depending on the films. It's how it is wise to have a CD, load the CD and look at the CD, and how prone imaging can really make a difference in actually diagnosing transient conditions and real conditions. So thank you, sir, for that wonderful insight. And I would like to invite Dr. Vijayanand, sir, now to tell us more about the radiologist perspective and different things what we expect to see as a radiologist in today's topic, which is HRCT in interstitial lung disease. Over to you, sir.
Thank you. Thanks a lot, Dr. Deepak, for this kind introduction. And I once again thank Dr. Vijay Kumar, sir, for graciously accepting to be on this platform of the Clinical Radiological Meet today of the VDC webinars. So as we can see, the topic for today is ground glass to honeycombing, the role of HRCT in interstitial lung diseases. So when I'm telling this ground glass to honeycombing and then HRCT, there is definitely a very significant contribution or relation between these two, because one is the pathology and another is the imaging modality that helps in diagnosing. So what I want to tell when Vijay Kumar sir told that HRCT is a boon to him, though he being such a big senior pulmonologist, I request my fellow radiologists that they have to use this modality very efficiently. Basically, I want to tell them that like understanding this HRCT is like learning a new language, the language of the patterns of on HRCT. Okay, basically keeps telling the stories of alveoli, airways, fibrosis, the function, and also the microarchitecture of lungs. So I request everyone, all the junior fellow radiologists to use it in a very efficient way and give the proper diagnosis that can help the patients and the clinicians in diagnosing and treating them. So without delaying much, I would like to go to in today's topic. So to define what exactly is the interstitial lung disease, it's an umbrella of the term used for large group of diseases that causes scarring of the lungs. So what happens when there is scarring? When there is scarring of the lung, it leads to stiffness of the lung. When this stiffness, because of the stiffness, there is loss of elasticity of the lung, and the expansion of the lung becomes less. Because of this, there is difficulty in breathing because the patient cannot breathe because there is loss of elasticity of the lung. And since the patient cannot take in sufficient amount of air inside, the oxygen produced also will be less that comes into the bloodstream. And because of that, the patient feels either discomfort or breathlessness, or patient becomes very weak. Okay, so these are all the sequelae of interstitial lung diseases. Okay, so because I told that there is a significant relation between the ILD and the HRCT, the most important thing that we need to learn in case of HRCT is the secondary pulmonary lobule. It's the basic anatomical unit of pulmonary structure and function. If you can see this, are we able to see the cursor?
So kindly move the cursor. Yes, sir, we can see it. Yes, sir.
Okay. So I think this is better. So what is exactly a secondary pulmonary lobule? Secondary pulmonary lobule, as you can see here, this is the pictorial representation and anatomical representation of this pulmonary lobule, where you can see a terminal bronchiole, pulmonary artery, interstitial, interlobular septum. This is the pleura on the lateral aspect, and the pulmonary vein along the interstitium. Okay, this is taken from the lung. Whereas on HRCT, how does this look? This looks like a polygonal structures along the within the lung, predominantly seen better in the periphery of the lungs. What you can see here is small green arrow. This is a secondary pulmonary lobule. They are usually about 1 to 2 centimeters in size, and they contain about, you can see these cottonwool like fluffy areas structures. These are the acini wherein the gaseous exchange take place. And for the interpretation of interstitial lung disease is based on the type of involvement of this secondary pulmonary lobule. So what are the types? It will be either a centrilobular or perilymphatic or random involvement of the lung, and secondary centrilobular and perilymphatic involvement of the secondary pulmonary lobule. You can see this blue color. What you are seeing is it is showing that the presence of the pathology is seen within this polygonal structure, which is a secondary pulmonary lobule. So it is called as centrilobular pulmonary pathology. And if you can see this yellow thing, this is along the pleura, along the interlobular septum, and also along the peribronchial vessels, which is called as perilymphatic distribution or perilymphatic pathology. Centrilobular pathologies are usually hypersensitivity pneumonitis, respiratory bronchiolitis, and centrilobular emphysema, whereas perilymphatic pathologies are like sarcoidosis, lymphangitis carcinomatosis, and pulmonary edema. And this is the HRCT wherein you can very clearly see where is the pathology. This is random, where you can see randomly discretely distributed structures. What yellow dots you are seeing are the nodular densities scattered without any definite area of involvement. Whereas if you can see the centrilobular pattern, you can see they are very well, be it either a single nodule or multiple nodules, conglomerated nodules, but the pathology is within the secondary pulmonary lobule. So it's a central lobular distribution. And if you can see this perilymphatic distribution, you can see multiple small nodular densities along the fissure, along the pleura, along the interlobular septa, and also along the peribronchial vessels. So this is what I explained initially about the clinical symptoms. Patients come with the shortness of breath or cough or fatigue or chest discomfort because of the decreased oxygen that is supplied into the systemic circulation because of non-production, because the sufficient amount of oxygen doesn't come into the systemic circulation as there is decreased lung expansion. So how to interpret? This interpretation is very, very important for the radiologists as well as the pulmonologist or the clinicians, because we have to give the report in such a structured way so that we are able to deliver what we are planning to tell. Because if we read the report, it should be able to be the other radiologist sitting on the other corner of the room or other side of the telephone should be able to understand what exactly the diagnosis I am supposed to give. And similarly, the clinicians also will be able to understand by looking at the terms what we are using. So there are a few questions that we need to answer while reporting a HRCT. They are like, what is the dominant HRCT pattern? They can be either reticular, nodular, high attenuations. High attenuations can be either ground glass or consolidations, and low attenuation like it could be emphysema or cysts. This is the dominant HR pattern. So where is this pathology located? Whether it is centrilobular, perilymphatic, or randomly distributed. Is there any upper versus lower zone involvement or central versus peripheral involvement? This also has to be answered. If we answer this, almost 80 to 90% of the diagnosis will be confirmed. And over that, if we get to know about the additional findings like the pleural fluid, lymphadenopathy, and traction bronchiectasis, we can definitely confidently give the diagnosis. So this is the normal HRCT axial section taken at the level of the heart. This is the most important slide for today, because whatever I am going to tell today will be in relation with the axial CT of just chest, because this is a normal one. So whatever pathology I'll be telling will be based on that. This is normal. So what is the abnormal finding according to this normal CT? Okay, so everyone, if any non radiologists or non-clinicians are listening to this, please understand that this is one of the most important slide, because this is a normal slide. So what I'll be showing going ahead will all be abnormal findings. So I was talking about the patterns. So what are the patterns? This is the first and foremost is the reticular pattern, what you're seeing here. What does this look like? This is basically interlobular and interstitial septal thickening, which is seeing like a mesh-like or mesh-like networking all in the interstitium. You can see all these white lines within this lung in the background of a faint ground glass opacity. This is called as reticular pattern. You can see the second one. These are multiple discrete distribution of tiny nodular densities distributed all over the visualized lung. This is the nodular distribution or nodular pattern. Here, this is the third one. What you're seeing is it is not a totally dense like a consolidation, or not. It's not like a normal lung. It is basically in between. So this is a ground glass opacity. You can see a ground glass opacity in the anterior aspect of the right lung, as well as a small patchy opacity in the posterior aspect of the right upper lobe also. This is the ground glass pattern. Next is you are seeing well-defined, rounded, few small cyst-like areas. These are the cystic changes with a thin perceptible walls. Okay, very thin walls. So this is cystic pattern. Similarly, there are again cystic pattern here also, but the wall, if you can see, they are thick. Okay, this is cystic pattern, basically cystic bronchiectasis, and you can see here this where my pointer is there. This is a tubular cystic dilatation. This is a cystic bronchiectasis or tubular bronchiectasis. This is a cystic bronchiectasis and this is a tubular bronchiectasis. And the last one, you can see the red slide. This is a traction bronchiectasis. Okay, and what you can see all over your multiple small like honeycombing like or multiple layered honeycombing pattern. What you can see is the honeycombing pattern. Basically, this is one of the CT findings for end-stage lung disease. So there are more than about 100 entities of interstitial lung diseases. Fortunately, we have only about 10 of these are very important and they contribute to about 90% of the interstitial lung diseases. Okay, so we need to understand what are these common interstitial lung diseases and how can we diagnose. Okay, this is the classification. The classification of interstitial lung disease, wherein we know the etiology in some and we don't know the etiology. The known etiology causes are because of the interstitial lung disease happening because of the inorganic exposure like asbestosis, because of asbestos, then silica exposure, hard metals, and coal dust. And the organic exposure, that is the diseases that can be spread because of these are the birds, hay, mold, and mycobacteria. Smoking-related interstitial lung diseases are like DIP or discomitative interstitial pneumonitis, respiratory bronchiolitis-related interstitial lung disease, and LCH. Okay, and the drugs, the multiple drugs are there. Few of the important ones are nitrofurantoin, amiodarone, methotrexate, and chemotherapy. And a few connective tissue disorder-related interstitial lung diseases are rheumatoid arthritis, polymyositis, dermatomyositis, scleroderma, and Sjogren's syndrome. Few of the interstitial lung diseases where we don't know the etiology are rare forms of interstitial lung disease like lymphangiomyomatosis and vasculitis of certain types. Then granulomatous diseases like sarcoidosis. Then idiopathic interstitial pneumonias are there. There's a separate classification again wherein we can find IPF or idiopathic pulmonary fibrosis and non-IPF things. Non-IPF again is classified into NSIP, cryptogenic organizing pneumonia, lymphocytic interstitial pneumonia, and acute interstitial pneumonia. Okay. So we'll come directly to the pathology part. First and foremost is the sarcoidosis, which is one of the commonest interstitial lung disease we come across. We have common findings and uncommon findings. The common findings are small nodules in a perilymphatic distribution. This is very important, one of the most classical sign. Then we have upper and mid-zone predominance and lymphadenopathy in right hilum, left hilum, and paratracheal region. And uncommon findings are conglomerate masses in a perihilar location. Larger nodules can be seen. They are wherein they are seen very close to each other with the mild spiculated margins will be there, and then have multiple small satellite nodules around it, which can form a galaxy sign-like appearance. And sometimes the nodules can be so small or tiny that they appear as a ground glass opacity, which is also known as alveolar sarcoidosis. Sarcoidosis basically can be both like a mediastinal, basically lymph nodal, parenchymal, and mixed. Okay, so this I'm just showing in general. Well, this is an X-ray, just showing it because we always remember about the bilateral symmetrical lymph nodes in the perihilar region was one of the main diagnostic point for sarcoidosis. So this is how it looks. They are low. You can see bilateral symmetrical opacities in the perihilar region. The same thing what we are seeing here is, right, I told about 1, 2, 3 sign there in HRCT. Here there's the lymph node in the right hila, left hila, and paratracheal region. This is also known as 1, 2, 3 sign. And what you're seeing here in the CT, yellow and red arrows, what you're seeing are perilymphatic distribution of nodular densities. You can see here, multiple tiny, here, 1, 2, 3, the red arrows where the pointing. Multiple nodules are seen along the fissure and then along the peribronchial vessels. This is the advanced sarcoidosis. There is a chest X-ray for that, and we can see the HRCT also here. This wherein we can see progressive fibrosis in case of sarcoidosis. Okay, wherein we can see multiple irregular nodular opacities or consolidation-like areas with multiple discrete satellite nodule-like areas around it. And as in association with, in addition to this, we will also be having the typical perilymphatic distribution type of involvement. Okay, the whenever there is consolidations, these larger consolidations, they usually affect the posterior aspects of the upper lobes. Other diseases that commonly result in similar appearances are silicosis, tuberculosis, and talcosis. This is alveolar or sarcoidosis. Here, basically, if you can see here, the bilateral upper lobes, you are seeing a ground glass opacity-like area. Okay, but you can see here, if I can magnify it, actually they are a group of multiple tiny nodular densities which are causing this type of picture. Okay, so basically this is a alveolar sarcoidosis. Coming to silicosis and cold workers pneumoniosis, they are again pathologically distinct entities from sarcoidosis, and histologically also they are different, and they are caused because of the inhalation of different inorganic dust. Silicosis and CWP they occur in a specific patient groups like construction workers, mining workers, workers exposed to sandblasting, glass blowing, and pottery. Okay, and radiographic and HRCT pattern appearances of these cannot be distinguished with the sarcoidosis, but basically they are because of the history we'll come to know what would be the clinical diagnosis. And however, we need to understand that is basically occupational hazard, and the sarcoidosis is far more common compared to the other two diseases. What are the findings in case of silicosis and cold workers pneumoniosis? They are like well-defined nodules in both the lungs. Basically, they also prefer the upper lobes. Nodules can be classified, and they are usually centrilobular and subpleural distribution. However, random can also be noted sometimes. And these irregular conglomerate masses, also known as progressive massive fibrosis, can be seen in this axial CT. Okay, they are large, irregular, nodular, show with a loss of architecture of the lung and decrease in the lung volumes. In addition, they can also have classical calcified lymph nodes, what we know as eggshell calcifications. Coming to the next one is the lymphangitis carcinomatosis. It basically happens because of the hematogenous spread of malignancy to the lung because of the invasion of interstitium and lymphatics. Okay, what happens here? Basically, the dyspnea and cough, they can predate the radiological abnormalities. And sometimes in many cases, it can be even asymptomatic. And these are normally seen in most of the malignancies like breast, stomach, lung, pancreas, cervix, etc. and adenocarcinomas. Okay. So what is the HRCT findings here? They are intralobular septal thickening. You can see this one. I told about the reticular pattern initially. This is fitting the reticular pattern. Okay, there is intralobular septal thickening with the thickening of the fissure you can see here. And if you can see here, I can show you two different type of interstitial thickening. One we can see here is a smooth interstitial thickening along the fissure, and we can see small nodular areas of thickening of the septa here. Okay, this is normally because of, in case of lymphangitis carcinoma, it can happen either because of the infiltration by either tumor cells or by the fluid. Okay, normally what we can see here, this smooth thing is because of the fluid, and this nodular thing is because of the tumor cells invading into invading into the interstitium. Okay, and this thickening, this can be either focal. The abnormality, what I'm talking about, the lymphangitis carcinomatosis can be on focal on one side, and there can be usually hilar lymphadenopathy in about 50% of the patients, and the patients can also have pleural effusion in around 50% of the patients. So now the differential diagnosis, Vijay Kumar sir was initially telling that this cardiogeny or the pulmonary edema can also simulate the interstitial lung disease. And he also gave the explanation how to rule out. He told about the prone position should be done in, because all the fluid will keep down along the dependent part. This is again similar. Sometimes it can be a very tricky mimic to rule out lymphangitis carcinomatosis from the cardiogenic pulmonary edema. Here, what we are seeing here again, that this reticular pattern of interstitial thickening is seen, and also pleural, the fissure is also thickened, and there are few thickened atelectatic bands as well. And if you can concentrate, you can see all the bilateral pleural effusion also is seen. Okay, so basically it's a case of cardiogenic pulmonary edema with perihilar gravitational dependent faint haziness in or wheel-like opacities in bilateral lower lobe along the dependent part, and there is usually associated cardiomegaly and bilateral pleural effusion. The differentials, as I already told, will be lymphangitis carcinomatosis, interstitial like viral or mycoplasma pneumonia, then acute respiratory distress syndrome, which normally spreads very fast, and then pulmonary hemorrhage can also be a DD. So coming to hypersensitivity pneumonitis. Hypersensitivity pneumonitis is also known as extrinsic allergic alveolitis. It happens because of the variety of antigens like farmer's lung, bird's fancier's lung, or hot tub or lung, or humidifier lung. Okay. The radiological and pathological abnormalities can be classified into acute, subacute, and chronic stages. Most of the patients that come to us will be in the subacute or the chronic phase, because initially the patients, they are in the acute phase. They don't come to the radiology like CT. Maximum they may usually come to the X-rays, but in X-ray most of the time it becomes normal. But if HRCT is done at that stage, initial stage, we can find either it can be normal, or it will show a faint air trapping areas, or it can show tiny nodular densities, very tiny nodular densities, which we normally think of could be because of some airway disease. Okay, this is what we get confused. But when the patients present in case of subacute and chronic stage, we can confidently diagnose the subacute interstitial pneumonitis. What will be the findings in case of subacute hypersensitivity pneumonitis? They are ill-defined centrilobular nodules of ground glass opacity in approximately about 80% of the patients. And there will be, you can see here, irregular faint fibronodular densities are seen in both the lungs. And if you can see in this down picture, HRCT in the lower picture, you can see air trapping with mosaic attenuations. Air trapping, these lucent areas are all the air trappings, and this faint haziness is the mosaic attenuations, and faint ground glass opacities can be seen around it because of the bronchiolitis. Another one of the important classical signs we find in hypersensitive pneumonitis, subacute hypersensitive pneumonitis, will be irregular fibronodular densities in the subpleural location with a very clear separation or demarcation line between the pleura. You can see the subpleural line is very clear. You can see there is a very nice pairing seen. Okay. This is case of a chronic hypersensitivity pneumonitis, which is an advanced case of hypersensitivity pneumonitis, wherein you can see there is multiple, there is basically mosaic attenuations, patchy areas of ground glass opacities, as you can see in both the lungs. Then you can see a few thickened septae will be seen. Okay, and you can also see architectural distortions along with the intralobular and interstitial septal thickening. You can see here septal thickening is there. Small lucent areas are actually the air trapping. Okay, and then this is all the patchy areas of ground glass opacities. This is one of the classical pictures of chronic hypersensitivity pneumonitis. Coming to chronic eosinophilic pneumonia, it's an idiopathic condition characterized by filling of the alveoli with eosinophils. Patients can present with fever, cough, weight loss, malaise, and shortness of breath. Symptoms are often severe and usually last for 3 months, and they promptly respond to the steroids. Okay, how does this look? It's a classical picture. If you find chronic eosinophilic pneumonia, either X-ray or CT, we can easily, it's basically a spotter-like appearance. Peripheral consolidation with upper lobe predominance, or we call as photonegative of pulmonary edema. Okay, there are other few differentials also, like organizing pneumonia, what sir was telling during introduction. Then localus pneumonia, like eosinophilia, where is vanishing peripheral consolidations will be there, and then Church-Ross syndrome and pulmonary infarcts. This is a very classical picture of chronic eosinophilic pneumonia, wherein you can see very well-defined areas of consolidation along the periphery of the lung here and along the posterior aspect of bilateral lungs. And you can see this part, central part is, and central and the perialar areas are spared. This is called as the reverse batwing sign appearance. Even on the X-ray also, it looks similar to this. And there's a close differential here. What we are seeing here is the cryptogenic organizing pneumonia, wherein you find multiple areas of irregular consolidations. Okay, but you don't, there are a few other findings in addition to the chronic eosinophilic pneumonia in case of cryptogenic organizing pneumonia, which I will discuss in the coming slides. So, but this is a close differential for chronic eosinophilic pneumonia, and basically we have to do correlate with the lab findings to ascertain this diagnosis. Coming to pneumocystis cardiopneumonia, it's also called as pneumocystis jirovecii pneumonia, and the patients normally PCP used to be very dominant in the HIV infected patients, but because of the new antiviral drugs, the PCP has come down in case of HIV patients, but PCP nowadays is more seen in case of immunosuppressed patients, in transplant recipients, and patients on chemotherapy. So what are the HRCT findings there? They are diffuse ground glass opacities in bilateral lungs. As you can see in this top picture, they're associated septal thickening, interlobular septal thickening, and few atelectatic bands can also be seen along the dependent part. Then there can be pneumatoceles. These small cyst-like areas are seen in case of PCP or JCP also. And you can there is also a faint background of patchy ground glass opacities or mosaic attenuations along with this. And the cysts can be well defined and can also be bizarre in shape. And because of the therapy, these can either eventually regress or completely disappear, or can become like a residual nodules or scars. And one important thing here is again pneumothorax. Because of the rupture of these pneumatoceles, the patients with pneumatoceles can have approximately about 35% of the patients can have pneumothorax. Coming to ARDS, acute respiratory distress syndrome, is again a sudden life-threatening lung failure requiring mechanical ventilation. Can be pathology I will not be explaining, but it can be of two types: primary pulmonary, the risk factors are aspiration, pneumonia, then toxic inhalation and pulmonary contusions. Extrapulmonary risk factors are sepsis, pancreatitis, multiple blood transfusions, trauma, or drugs. Okay, mild form of ARDS may resolve completely, while severe forms, they result in irreversible fibrosis. And the query that why some people develop ARDS and why some people do not is still unknown. So what does the picture of ARDS look like? You can see this first picture when you can see large irregular areas of consolidations or ground glass opacities, and minimal some effusion also can be seen. This is a post PEEP, okay, post PEEP wherein you can see anterior part are showing small cystic areas, okay, subpleural cyst like areas are seen along with rupture of few cysts causing pneumothorax anteriorly. This is again a bizarre shaped irregular cyst can be seen in the parenchyma along with the consolidation or ground glass opacities. Few irregular linear septate or irregular fibrosis can also be seen in case of pulmonary ARDS post PEEP or ventilation post PEEP. And basically, it is said that consolidations have a protecting effect on the lung parenchyma. As you can see, the posterior lung are not showing much of fibrosis, whereas the anterior part are showing fibrosis because the consolidations were seen predominantly in the posteriorly. Okay, so this is one of the important thing. Coming to extrapulmonary ARDS, here the patient was involved in a case of road traffic accident, and you can see there is diffuse bilateral symmetric ground glass opacities like opacities or consolidation like areas in bilateral lungs. Okay, and basically it's a gradient. There is a gradient from top to bottom with consolidations in the dependent part bilaterally. And one of the important find here in case of extrapulmonary ARDS is the symmetry of abnormalities. Both the lungs show similar pathology. Coming to idiopathic interstitial pneumonias, they comprise a heterogeneous group of disorders, but they basically are a fundamental response of lung injury and do not represent diseases per se. And these diseases have specific pattern, which I'll be discussing in the coming slide. This is the classification: UIP, NSIP, COP, RVILD, and DIP, AIP, and LIP. Coming to UIP, or usual interstitial pneumonia, the differentiation between NSIP and UIP has tremendous prognostic implication for the patient. So it is basically it's a moral responsibility of the radiologist who reads the HRCT to try to give the best diagnosis possible, because the prognosis of the patients depends on this. And once if it is diagnosed, like UIP is diagnosed, they usually die within 3 years. Okay, so we need to be little proactive and give the diagnosis. The radiological appearance is, classical appearance is honeycombing, which I'll be telling you. Okay, and whenever you see a chest film with long-standing reticulations with lower lobe with a lower lobe and peripheral preference, if you are thinking in terms of any other differentials, you should also consider this as a DD. So what are the HRCT findings here? The classical sign is traction bronchiectasis and honeycombing. Okay, the layer honeycombing. What you're seeing, this is a typical case. You're seeing peripheral layered honeycombing along the bilateral chest walls, and you're also seeing traction bronchiectasis at few places. There is associated architectural distortion. As you can see, there is loss of normal morphology of the lung parenchyma, predominantly involving the basal and subpleural region. These patients can also have mild mediastinal lymphadenopathy. The differentials here can be the hypersensitivity pneumonitis, which I showed you in an advanced stage of chronic hypersensitivity pneumonitis. And then end stage sarcoidosis can also look similar to this, but most of the times they can have some others. Prominent lymph nodes. The lymph nodes will be usually larger in case of sarcoidosis, and lab investigations will help in ruling out that thing. And NSIP can also simulate this, but this NSIP should be a fibrotic variant of NSIP. So NSIP is histologically characterized by homogeneous uniform pattern of cellular interstitium associated with various degrees of fibrosis. NSIP is a very inhomogeneous group because it can be classified from type 1 to type 4, wherein type 1 is a cellular type, wherein you normally find the ground glass opacities or mosaic attenuation, basically ground glass opacities, whereas a fibrotic pattern will be seen in a later, in fibrotic pattern, you can see UIP-like picture. Okay. The predominant finding, as I told you, is a GGO or ground glass opacity. Very subtle traction bronchiectasis can be seen. And NSIP is by far the most common interstitial lung disease in patients with connective tissue diseases. These are the important pointers you need to remember. It's not a diagnosis on its own. It's a pattern of lung damage. The pathologist, the key feature is the uniformity of the abnormality within the lung. And the role of radiologist is more to exclude UIP pattern rather than make a diagnosis of NSIP. And the diagnosis of NSIP requires histopathological proof. And in all patients with NSIP, the clinician should be advised to look for the connective tissue diseases, hypersensitivity pneumonitis, or role of any drugs. So what are the findings on HRCT in an NSIP? They are, this basically is a case of a scleroderma, wherein you can see irregular areas of fibrosis along the subpleural region with small areas of opacities, irregular distributed opacities along the periphery. In the basal areas, you are seeing ground glass opacities with areas of subtle fibrosis. A small area of traction bronchiectasis is seen in the left lungular region. And other than that, patients can also have, the patient also has dilated esophagus here. But if you can see, there is a striking lacking of honeycombing, which is a classical picture of UIP. Yeah, that should be noted. This is another case of the same NSIP, where you are showing irregular areas of fibrosis, interstitial interlobular septal thickening, then faint patchy ground glass opacities, and subtle traction bronchiectasis in the right middle lobe here. Cryptogenic organizing pneumonia, normally it used to be previously described as BOOP. Okay, but basically it's an inflammatory process characterized by organization of the exudate. Basically, it's an unresolved pneumonia. Okay, it is called as basically we think it has to be as idiopathic, but there are certain instances wherein we have the history of pulmonary infection, drug reactions, then collagen vascular diseases, vaginal granulomatous, and after toxic fume inhalation also these type of pictures have been noted. OP or organized pneumonia presents with several month history of non-productive cough, low-grade fever, malaise, and shortness of breath. It gives a good response to corticosteroid therapy and has a good prognosis. So diagnosis becomes very important again. So what are the findings here? I showed the picture previous, when I showed the chronic eosinophilic pneumonia, I showed the finding on HRCT, where you can see bilateral peripheral consolidation. They are very sharply demarcated, though they can be irregular spiculated, but they are sharply demarcated. The consolidations can be migratory, and they show pleural tags or spicules. Okay, and because of that, they can be again confused with bronchoalveolar carcinomas or bronchogenic carcinomas. And then bronchial wall thickening and dilatations can be seen in few patients. And in addition to pleural thickening, small pleural effusions, and parenchymal band. Okay, the diagnosis, basically, again, it's a diagnosis of exclusion after excluding lymphoma, infection, infarction, and malignancy. This is a picture where you can see multiple irregular masses. In addition, you can see small patchy irregular opacities, septal thickening, irregular small nodular and fluffy opacities. And there are also septal thickening and peripheral consolidations. And these consolidation can show vanishing. Coming to RV-ILD and DIP, respiratory bronchiolitis and respiratory bronchiolitis associated interstitial lung diseases and DIP, they represent different degrees of severity of the small airway disease or because of the cigarette smoking. All the smokers have various degrees of bronchiolitis, but usually it's asymptomatic. And radiologically, however, these diseases cannot be clearly separated because of the overlap of CT findings. We have certain HRCT findings which will help us to diagnose along with the history. What are the findings here in case of RV-ILD? Like central luminal nodules of ground glass opacity, predominantly involving the upper lobes. Bronchiolitis is there. Because of that, we have the bronchial wall thickening. Then secondary lobuli with decreased attenuations, and we have air trapping. Ground glass opacifications can be seen in few patients along with the intralobular septal thickening. Okay, usually these patients will also have smoking-induced central lobular emphysema, and there is a evidence that respiratory bronchiolitis is the precursor of emphysema. Coming to DIP, it's again a similar spectrum only. It shows the diffuse areas of ground glass density in the lower lobes with some mosaic pattern as a sole abnormality. Reticular abnormalities and signs of fibrosis are typically absent. Okay, so fibrosis and reticular abnormalities are absent. This you need to remember. And these abnormalities are usually reversible on stopping the smoking. AIP is acute interstitial pneumonia, or usually initially called as Hammond-Ridge syndrome. It's a diffuse alveolar damage with subsequent fibrosis, and usually they are fatal. The HRCT findings in AIP are indistinguishable from acute respiratory distress syndrome. Okay, HRCT shows a diffuse patchy consolidations, ground glass opacity, often with crazy paving pattern. Okay, and there is a rapid progression in case of acute interstitial pneumonia. This is the picture of acute interstitial pneumonia, wherein you can see diffuse, irregular, patchy areas of consolidation in bilateral lungs with areas of septal thickening and background subtle pleural reaction, as well as mosaic attenuations. If you can concentrate, if you can correlate this, I had shown the similar picture with chronic hypersensitivity pneumonitis also. So this is one of the differential diagnosis for that. Coming to lymphocytic interstitial pneumonia, it's seen mainly in patients with autoimmune diseases, particularly Sjogren's syndrome and patients with AIDS. The symptoms are non-specific and those of patients' underlying diseases. Okay, HRCT findings are usually asymptomatic, but if you want to diagnose the cystic lung diseases, we need to remember this picture. This is a case of LIP, and if you can concentrate here, the arrow what I'm pointing. This is a case of lymphocytic interstitial pneumonia, where you can see faint area of background wheel-like ground glass opacity or patchy opacity, and then you can see thin walled cysts distributed, like very few cyst-like areas are seen. This is a case of lymphocytic interstitial pneumonia. Other uncommon similar cystic interstitial lung diseases are lymphangiomyomatosis. This is exclusively seen in premenopausal women, okay, characterized by progressive proliferation of the muscle cells, which I'm not going to tell in detail. The clinical findings are majority of the patients present with dyspnea. There can be chylous effusions, pneumothorax, and hemoptysis in these patients. Patients usually die within 10 years of the onset of symptoms, and pregnancy may exacerbate the disease. So you can see this picture I showed you for the classification of cystic lung disease. The blue arrow pointing lymphangiomyomatosis. What you're seeing, multiple thin walled cysts, okay, distributed in both the lungs. If you can see the number, both these LAM and LCH look similar, but the margins of the lung are very well maintained in case of LAM, and there is associated pneumothorax. Okay, and also this is exclusively seen in premenopausal women. Okay. Coming to Langerhans cell histiocytosis, also known as eosinophilic granuloma of the lung. Okay, usually patients have history of smoking, and patients can show irregular cystic areas of bizarre shape. You can see here bizarre shaped irregular areas will be seen in both the lungs. Okay, this is a case of LCH. Okay, initially these can be seen as a small nodular densities, also like centriluminal or fluffy opacities, which should not be confused with the other interstitial lung diseases I told initially, like acute hypersensitivity pneumonitis or subacute hypersensitivity pneumonitis. Coming to drug-induced, basically it's a diagnosis of exclusion. If you are not having any history, if you're not if you have a history of drug intake which can cause interstitial lung disease, and clinically if it is not fitting into any other diagnosis, because then we can fit into the drug-induced interstitial lung disease. Again, this can show a variety of plethora of findings can be seen. Basically GGO, traction bronchiectasis, honeycombing, fibrosis, anything and everything can be seen. Coming to the alveolar proteinosis, it's a rare disease characterized by filling of alveolar space with PAS positive material due to the abnormality in the surfactant material. This is actually a spotter on diagnosis. This is called as this is a interstitial thickening, or like a reticular interstitial thickening in a background of ground glass opacity. Okay, this is called as a crazy paving pattern. It's a spotter, usually between 30 to 50 years, and patients are present with non-productive cough and fever, and the prognosis has improved since the advent of treatment using bronchoalveolar lavage. The differentials for alveolar proteinosis can be non-cardiogenic edema like ARDS and acute interstitial pneumonia. And these can also be, but they have other pneumonia like infections like PCP, CME can also sometimes simulate them. So the take-home point for today is HRCT is basically forms the cornerstone because it defines the ILD patterns. Since I was talking about the patterns, so we need to keep in mind that it's a cornerstone because we can identify the pattern very crisp and clearly. Second thing is context matters. Always correlate with the history and the lab findings. And whenever you have some doubts, talk to the clinician so that they can give you a very good idea of what exactly the diagnosis can be. And patterns guide prognosis, wherein, because as I was talking about the patterns, if we follow the patterns, it can help us in leading to the diagnosis, and that keeps telling us the imaging impacts the therapy and outcomes and helps the better diagnosis and better management. Okay. Thank you. If there are any other questions, are there? I'm open for the questions. Thank you.
Thank you, sir. Thank you, Dr. Vijayanand, sir, for that lucid talk covering comprehensively all the spectrum of interstitial lung diseases, and also stressing how important as a radiologist it is to correctly pinpoint the diagnosis, or at least narrow down the differentials to guide the clinician in the right path. So also highlighting how crucial it is for HRCT in the diagnosis and follow-up in patients with interstitial lung disease. I would like to take this liberty to ask one question to our speaker, Dr. Vijayanand, sir. A lot of clinicians ask us what request us for a low-dose CT. So kindly, for the benefit of the audience, kindly let us know what a low-dose CT is and how we use it generally.
Okay. Low-dose CT, as the name suggests, basically it's a CT scan which gives very less radiation to the patient. Approximately about 30 to 70% of the radiation is can be decreased to the patient because of the low-dose CT. Where we use it is we can use it. Basically, it is used in case of screening. Screening, like in case suppose we find a pulmonary nodule, we just cannot keep on. We just we cannot just keep following it up with a standard CT wherein radiation is more. We can use a low dose CT wherein the follow-up of the patient can be seen better with less amount of radiation. Or it can be also used in case of for screening of the malignancies or whole body CTs, or sometimes even in the pediatric patients. Okay, basically what we do here is like we use the low tube current. Basically, if you take the technical aspect, we use a low voltage, and then the exposure, automatic exposure controls can be used to decrease the CT to the radiation to the patient. Basically, it helps in decreasing the radiation to the patients.
Right. Thank you, sir. Thank you, sir. I have one or two couple of questions. I'll take the liberty to ask Dr. Vijay Kumar, sir, our chief guest today. Sir, as a clinician, when you send patients for HRCT in interstitial lung diseases, how important is it, and what are the parameters or findings you look at in HRCT while you follow patients with interstitial lung disease to assess disease progression, whether there is improvement or deterioration? What are the parameters generally as clinicians we look at? Can you kindly let us know?
Yeah, thank you. Before answering the question, I would like to congratulate Dr. Vijayanand for the extensive and exhaustive talk on HRCT and ILD. It is very difficult to give a talk on this topic, and it is much more difficult to understand what the speaker is saying. So each one of the diseases that Dr. Vijayanand mentioned itself is a very long discussion, long lecture. From what I have heard and learned in the last several years, I had difficulty in understanding the different patterns, because what Vijayanand mentioned was the pattern. Recognize the pattern, because that is what is going to give the diagnosis. And a very important point he mentioned was the context. The context is the history. So as clinicians, all of us are supposed to take down or ask the patient for a very meticulous history and a meticulous physical examination. And not all diagnosis is done solely dependent upon the HRCT. For example, IPF, idiopathic pulmonary fibrosis, pulmonary edema, are based on a meticulous clinical background. And similarly, connective tissue disease related ILD is based on physical examination, history, and serology. And when it comes to sarcoid, although radiology will give us enough indications, ultimate diagnosis is based on the histopathology, either by sampling the lymph node or sampling the parenchyma. And as I was saying, history is so important, especially in the case of hypersensitivity pneumonitis, whether it is because of the pigeons. And I get a lot of patients who spend hours and hours sitting in a small puja room, doing puja with a lot of agarbattis and a lot of dhoop sticks, and housewives who are cleaning the bathrooms with the harpic and things like that. They develop acute hypersensitivity pneumonitis. And similarly, silicosis is an occupational lung disease, and history itself will point towards the diagnosis. Having said this, I look at honeycombing as 3S. That is, honeycombing is small cysts which are several layers stacked on each other, and they're sharing the walls. Yes. Several layers sharing the walls and stacked on each other. And similarly, for idiopathic pulmonary fibrosis, I always remember the acronym SBH. That is, the honeycombing is basal and subpleural. So this is very characteristic of this. And now, of course, the new classification has come from ERS and ATS, where for the hypersensitivity pneumonitis, they said it will be divided into non-fibrotic and fibrotic. Earlier, we used to say acute, subacute, and chronic, but now it is simply fibrotic and non-fibrotic. And whenever we want to know whether there is any fibrosis because of the interstitial lung disease, all that we have to do is put our stethoscope at the back in the infrascapular area and ask the patient to take a deep inspiration. And if you hear nice crackles at the end of the inspiration, like a series, they are called Velcro type of rails, Velcro rails. If you find Velcro rails at the bottom of the lung, posteriorly, infrascapular area with your stethoscope, it means it is indicative of fibrosis. It could be IPF, idiopathic pulmonary fibrosis, or a fibrotic variety of hypersensitivity pneumonitis. And sometimes even connective tissue disease related ILD, when it goes into fibrosis, also can produce this kind of Velcro rails. Now, coming back to Dr. Deepak's question, whenever I want to assess the progress of interstitial lung disease in a given patient, the response to the treatment, it is different things for different people. For example, certain diseases like sarcoidosis, acute hypersensitivity pneumonitis, cryptogenic organizing pneumonia, I would like to see the change in the HRCT after starting them on the treatment. It could be after 4 weeks or 6 weeks. But then there are certain diseases like idiopathic pulmonary fibrosis where you don't see much change between one CT scan and another CT scan over a period of time, even with treatment. They only keep on worsening and they don't get better. So, but these diseases like cryptogenic organizing pneumonia or acute HP and sarcoidosis, they respond beautifully to the treatment, and we can see the improvement happening in the repeat CT scan, which can be after 2 months or 3 months. Like Dr. Vijayanand mentioned, the low dose CT scan, I would like to use it for my patients who are smokers, more than 30 to 40 pack years, where I am suspecting a lung cancer, and I want to see whether they have lung cancer. So they are asymptomatic, but they are smokers. So low dose CT scan is ideally suited for them. And if I want to repeat the CT scan, maybe after 2 years or 3 years, this low dose CT scan comes very handy. So depending upon the disease, I would look for the response to treatment in different diseases at different points of time.
Thank you, sir. One last question, if time permits. Although this is just outside the topic, but how vital was the role of HRCT during the pandemic of COVID in diagnosis and management, and also in the follow-up of patients with sequelae of COVID pneumonia? How, in your perspective, how important was it to have this important tool at our, at our hand? How was HRCT beneficial overall?
Yeah. HRCT played a huge major role during the COVID-19 pandemic. There were many times where the patient had the symptoms of COVID-19, and sometimes the throat swab used to come negative. But then the HRCT was so sensitive and so specific that simultaneously when we did the throat swab as well as the CT scan used to throw up the early changes of COVID-19, whether it is the form of ground glassing or subtle pneumonias, etc. And that has hastened up the diagnosis, and we were able to start the treatment very fast. And HRCT shows the characteristic lung damage which happens in COVID-19, especially the ground glass opacities, sometimes even consolidation. And what is more important is the HRCT used to tell us the percentage of damage which happened in because of the COVID-19. So it was very useful for diagnosis with and without throat swab. And it was also very useful for prognostication purposes. And many patients who had extensive shadows in the CT scan, we take a repeat CT scan after 1 month, everything disappeared. So that goes to show that the treatment given to these patients was excellent, whether it was steroids or roflumilast or the other remdesivir, whatever drug was given, they responded beautifully, and the CT scan was there to prove that everything has been eliminated. So a similar way, the HRCT plays a very important role in looking at the post-COVID sequelae in these patients. In many of the patients where the treatment was started little late, or where there was very extensive damage to begin with, the shadows never went away completely. So they persisted. They persisted in the form of interstitial thickening, crazy payment pattern, and when patients are still symptomatic, they still have cough, they are still breathless on walking, they are breathless on going up the staircase. And when we do the lung function test, the spirometry, which showed forced vital capacity percentage, predicted percentage was much less. Normally, it should be 80%, but in these patients, it was less than that, something like 60, 50, or even 40%. That goes to show that the COVID-19 has produced a permanent damage in the lungs because of late recognition of the disease and because of improper treatment started and because of the poor health status of each individual patient. It could be diabetes, it could be elderly age, or it could be poor nutrition, whatever it is. So HRCT played a big role, not only for diagnosis, but also for prognostic purposes.
Thank you, sir, for that wonderful insight. And I think there are no further questions. And I'm really happy being a radiologist. I've heard such wonderful, firstly, clinical inputs from Dr. Vijay Kumar, sir, and also extensive details about radiology perspective by Dr. Vijayanand, sir. And it's really a pleasure that I witnessed it. I'm sure our audience also would have gained valuable insights into this particular topic. On behalf of Vijaya Diagnostic Center, I would like to thank our chief guest, Dr. Vijay Kumar, sir, today, and our speaker, Dr. Vijayanand, sir. Since there are no further questions, I would, I think, like to end the session. Thank you very much. Thank you all for your patient hearing.
Thank you.
Thank you. Thank you very much.